Hello everyone, good afternoon. A very warm welcome to all of you to today's CCR presentation. I'm Dr. Nidhi Soni, faculty from the Department of Geriatric Medicine. So today we'll be presenting a case of a 73 years old male who came with history suggestive of Parkinsonism with bradykinesia, rigidity and tremors of a short duration. And under these clues lies the story which is waiting to get unfold. So I will request my residents, Dr. Chirag, for the case presentation and Dr. Rajkumar for the review of literature. Dr. Chirag, please.
Good afternoon, everyone. Presenting the case, Deciphering the Puzzle, a case of unusual neurological decline. 73-year-old male patient, physician by occupation, resident of Delhi, non-alcoholic, non-smoker, presented with the chief complaints of history of altered behavior for last 3-4 days, history of tremors and stiffness of both hands and legs for last 10 days, and history of lethargy and generalized weakness for last 1 month. Patient was apparently well, maintaining his daily activities and going to his clinic every day. But from last 1 month, he started feeling lethargic and used to skip his clinic and rest at home. Patient also complained of generalized weakness for the same duration. And that was associated with low mood, reduced oral intake, and reduced self-care and self-hygiene. Patient also complains of tremors for last 10 days. That was bilateral symmetrical coarse tremors present even at rest and initially present over hands and later progressed to involve lower limbs also. That was associated with stiffness of all 4 limbs, slowness of movements, slow short steps while walking, and abnormal orofacial movement. Patient also had a history of abnormal behavior for 3 days in the form of irrelevant talk, excessive anger outbursts, and history of reduced sleep for last 3 days. Patient had no history of fever or rash, no focal neurological deficit, no sensory cranial nerve involvement, no loss of consciousness or seizure episode, no complaints of vomiting or any abdominal complaints, no history of trauma or recent vaccination. Patient also had history of cholecystectomy done 30 years back and diagnosed with hyperthyroidism 35 years back, started on tab carbimazole for 3 months, followed by radioablation. Patient was a known case of hypertension on tab amlodipine for last 1 year, hypothyroidism that developed post radioablation on thyroxine 125 microgram, coronary artery disease on tab ecosprin and atorvastatin, taking tamsulosin for his BPH complaints, and had osteoarthritis of bilateral knee joint. Patient had complaints of constipation that was present for last 1 month, increased urinary frequency, and altered sleep pattern for last 3 to 4 days. So clues till now, patient is a 73-year-old male patient, had complaints of tremors, generalized weakness, slowing of movements with stiffness, and altered behavior with an acute to subacute onset. On general physical examination, patient was conscious, oriented to time, place, and person, with GCS of E4, V4, M6, and stable vitals, and unremarkable physical findings. On neuro examination, patient MMSE was 13 out of 30, with motor examination revealed increased tone in bilateral upper and lower limbs in the form of bilateral cogwheel rigidity. Power of both right and left upper and lower limb was 4 minus, and normal response to deep tender reflexes was there. Patient's cranial nerve examination and sensory examination was normal, but there were cerebral signs that were positive, including past pointing present, and distal dyskinesia was also there. The gait of the patient was a wide-based cautious gait with swing to either side and toes flexed. Extrapyramidal signs showed cogwheel rigidity, resting post tremors that was present symmetrical bilateral, and bradykinesia was also there. There were no signs of meningeal irritation. Spinal examination was also within normal limits, and rest other examination that includes cardiovascular, respiratory, and abdominal examination was also within normal limits. So please till now, patient is a 73-year-old male patient, had acute to subacute onset of tremors, generalized weakness, slowing of movements, and altered behavior, with bradykinesia, rigidity, tremors, and positive cerebellar signs, and cognitive decline. So we thought of a rapidly progressive movement disorder with a huge list of differentials as follows. It includes vasculitis under vascular, encephalitis, HIV, AIDS, and syphilis under infectious cause, and 10MD encephalitis, Hashimoto encephalitis under autoimmune, rapidly progressive diffuse Lewy body dementia, Brand disease, and frontotemporal lobar degeneration under neurodegenerative disorders, and paraneoplastic syndrome. In hospital course, patient was found in delirium and had developed new onset dysarthria with diffuse coarse tremors involving lower limb, with increased rigidity and dystonia. Lab investigations revealed normal blood parameters with normal hemoglobin, leukocyte count, and platelet counts. Patient was found to be in mild hyponatremia with sodium levels of 121 on day 1, with normal kidney function test and liver function test. This CSF analysis was done with revealed normal counts, normal protein and sugar, negative bacterial culture and fungal culture, with negative ADA, gene expert, and VDRL, and negative cytology and autoimmune paraneoplastic panel. Also, pan-viral PCR and Lyme serology was also negative. Tumor markers of the serum were also within normal range. Autoimmune panel that consists of rheumatoid factor, ANA, and ANCA antibodies were also negative. Imaging done of ultrasound whole abdomen on day 2 revealed grade 2 fatty liver and grade 2 prostatomegaly. MRI brain that was done outside revealed diffuse cerebral atrophy with non-specific ischemic changes in supratentorial compartment. Now, patient was posted for throated brain scan to further delineate the differentials. I would like to call Dr. Yamini from Department of Nuclear Medicine to discuss this.
Good afternoon, everyone. The throated SPECT of the patient shows no evidence of presynaptic dopaminergic dysfunction in bilateral basal ganglia.
Now, with all these investigations done, the differentials will narrow down to autoimmune and paraneoplastic syndromes. To further delineate the differentials, the patient was posted for FDG PET CT scan, and I will again call Dr. Yamini to discuss the PET scan.
The FDG PET-CT MAP and transaxial fused images of the patient showed hypermetabolism in bilateral cerebellar hemispheres, bilateral mesotemporal cortices, and midbrain as arrow marked. Further, the cortex ID images shows hypometabolism in bilateral frontal and parietotemporal cortices. This hyper picture was suggestive of autoimmune encephalitis.
So the final diagnosis that we concluded was seronegative autoimmune encephalitis. Since patient symptoms were rapidly deteriorating, decision to treat on basis of PET-CT report was taken. Patient was started on pulse steroid therapy, but on day 3, patient had episode of GTCS and was started on antiepileptic therapy tube. After completion of 5 days of methylprednisolone on pulse, he showed showing improvement in his rigidity as well as tremors. He was shifted to oral steroids and discharged and advised to follow up in on OPD basis. Currently, he is free of symptoms and oral steroids have been tapered down. This is the video of the patient at the time of discharge, showed improvement in the tremors as well as in the rigidity. This is the current video of the patient working at home 2 days back. So that's the case presentation. I would now like to call Dr. Rajkumar Tata, Senior Resident of Department of Geriatric Medicine, for review of literature.
Thank you, Dr. Chirag and Dr. Yamini, for the wonderful case presentation. So now let's dive into autoimmune encephalitis. Autoimmune encephalitis is a group of inflammatory brain disorders characterized by prominent neuropsychiatric symptoms and associated with antibodies against neuronal cell surface proteins, ion channels, and receptors. It is relatively a rare disease with incidence of 5 to 8 per 100,000 persons. The most frequently associated antibodies are anti-NMDR antibodies followed by anti-LGI1 antibodies. Since it is a rare disease, as physicians, we should have a high index of suspicion for all those patients who present with subacute onset of neuropsychiatric symptoms. And after ruling out possible common etiologies, autoimmune encephalitis should be a differential. So coming on to review of literature, this was a multicentric study titled Characteristic and Prognosis of Autoimmune Encephalitis in Eastern China, published in Frontiers in Neurology. According to this article, the most common clinical manifestations of autoimmune encephalitis is seizures in 79% cases, memory deficit in 67% cases, mental and behavioral symptoms in 59% cases. Hyponatremia is seen in 29% cases of autoimmune encephalitis. This was another article titled Therapy Response in Seronegative versus Seropositive Autoimmune Encephalitis. This article was published in Frontiers of Immunology. This was a retrospective study that analyzed 150 autoimmune encephalitis patients treated between 2010 and 2020. Immunotherapy, mainly corticosteroids, was administered. 92.5% of seronegative and 86.4% of seropositive cases shows improvement. This suggests that immunotherapy benefits both seronegative and seropositive autoimmune encephalitis patients, irrespective of antibody results. This was a case study of a 68-year-old woman with rheumatoid arthritis who presented with rapid cognitive decline, developed limb rigidity, hyperreflexia, and autonomic dysfunction. MRI revealed basal ganglia hyperintensity, but serology was negative for autoimmune encephalitis panel. So patient was started on methylprednisolone, but she developed gastrointestinal bleeding. Hence, the next line of treatment was plasmapheresis and rituximab. Patient showed full neurological recovery and MRI findings also improved. So the diagnosis requires clinical presentation and neuroimaging. Therefore, negative antibody tests does not rule out the disease. This was another article published in Indian Academy of Neurology. So according to this article, tools like APE2 and RIDE2 scores aid in early detection and treatment of suspected autoimmune encephalitis without detectable antibodies. This is APE2 score. So there are an array of antibodies which are associated with autoimmune encephalitis. The most common being anti-NMDR antibodies, anti-LGI1 antibodies, anti-Caspr2 antibodies, anti-GABA A receptor and GABA B receptor antibodies, AMPR antibodies, and DPPX antibodies. Among them, anti-LGI1 antibodies, Caspr2, GABA B, and AMPR are most commonly occurring in older adults. The most common being anti-NMDR antibodies. The key distinguishing feature of this autoimmune encephalitis is psychiatric features, classically orofacial dyskinesias, seizures, encephalopathy, and autonomic dysfunction, followed by anti-LGI1 antibodies, in which the key distinguishing feature is faciobrachial dystonia, seizures, hyponatremia, and amnesia. And these are associated with breast lymphoma, thymoma, and thyroid malignancies. So the antibodies associated with autoimmune encephalitis can be divided into intracellular and cell surface. The intracellular can be further divided into onconeuronal antigens and synaptic antigen. The common examples of onconeuronal antigens are HU, CMP5, RE, YO, MA2. They are associated in more than 70% cases with underlying tumor. The major pathogenic mechanism is cytotoxic T cell mediated, and they respond poorly with treatment. Only 10 to 30% cases respond with treatment. While the cell surface or synaptic receptor antigens, the common example are NMDR, AMPR, GABA receptors, LGI1, and Caspr2. The major pathogenic mechanism is antibody mediated, and patients who are treated shows 75 to 80% recoveries. So coming on to the diagnostic approach to any suspected case of autoimmune encephalitis. So the first step is confirm focal or multifocal brain pathology which is suggestive of autoimmune encephalitis. The first step is to do brain MRI with and without contrast, and if brain MRI is normal or patient is encephalopathic or having frequent seizures, then EEG is done. And if both are normal, then PET MRI, brain PET is done if MRI is negative and diagnosis remains uncertain. So in our case, MRI was normal and EEG was also normal. So the patient underwent PET. The common EEG findings in autoimmune encephalitis include epileptiform discharge and periodic lateralized epileptiform discharge. And in less than 1/3% of cases, the EEG pattern is extreme delta brush that is characteristic of this disease. The second step is confirmation of the inflammatory etiology and rule out competing possibilities. For this, we send neuronal autoantibodies with CSF and serum. And if still both are negative, then the patient undergoes brain biopsy. The third step is screening for associated neoplasm. The patient will undergo CT chest, abdomen and pelvis, followed by breast MRI and pelvis or testicular ultrasound. If the initial screen is negative, the patient will undergo whole body PET. MRI helps in ruling out other possible etiologies, and in 1/3 cases, the MRI can be normal. The most usually involved are limbic system, striatum, diencephalon, and rhombencephalon. Brain FDG PET is more sensitive than MRI and can reveal abnormalities in earlier stage of the disease. It shows bilateral temporal hypermetabolism in seronegative or seropositive limbic encephalitis and bilateral occipitoparietal hypometabolism in NMDR antibody encephalitis. So this is the 2016 gross criteria for autoimmune encephalitis. For definitive autoimmune encephalitis, patient along with signs and symptoms will have antibody positivity. The diagnostic criteria for possible autoimmune encephalitis include subacute onset of less than 3 months of working memory deficit, altered mental status, or psychiatric symptoms, and at least one of the following: new focal CNS findings, seizures which are not explained by previously known seizure disorder, CSF pleocytosis, or MRI features which are suggestive of encephalitis, with reasonable exclusion of alternative causes. So hence, all three should be met for the diagnosis of possible autoimmune encephalitis. Coming on to seronegative autoimmune encephalitis, the diagnostic criteria include rapid progression of less than 3 months of working memory deficit, altered mental status, or psychiatric symptoms, exclusion of well-defined syndromes of autoimmune encephalitis, and absence of well-characterized autoantibodies in serum and CSF, and at least 2 of the following criteria, which includes MRI abnormalities which are suggestive of autoimmune encephalitis, CSF pleocytosis, or brain biopsy showing inflammatory infiltrates, with reasonable exclusion of alternative causes. So all 4 has to be present for the diagnosis of seronegative autoimmune encephalitis. The occurrence of seronegative autoimmune encephalitis is 48% despite the availability of latest panel of antibodies assays as shown in this figure. Coming on to the treatment of autoimmune encephalitis. So any patient with suspected antibody-associated autoimmune neurological disorder, the first step is cancer screening. If there is cancer positive, the patient will undergo resection, chemo, and radiotherapy. If cancer screening is negative, the patient will receive first-line immunotherapy with IV methylprednisolone 1 gram daily for 3 to 5 days, with or without IVIG or PLEX. If the patient responds, we will continue with IV therapy or switch to oral steroids and re-evaluate the patient. If the patient is stable, we will taper off the steroids over 4 to 6 months. With successful tapering, if there is no relapse, it will be labeled as possible monophasic course and the patient will be followed every 3 monthly. But if there is confirmed relapse, the patient will again receive the first-line immunotherapy. If there is no response to first-line immunotherapy, the patient will receive second-line immunotherapy with rituximab and cyclophosphamide. If there is response with rituximab or cyclophosphamide, then we will assess the response, and if the patient is stable, we will taper off same over 4 to 6 months. But if there is no response with second-line immunotherapy also, so we will consider second-line immunotherapy trial with alternative agents like interleukin-1 inhibitors or bortezomib. The patient will undergo broad malignancy evaluation, or also we have to reconsider our diagnosis. So now I'll call Dr. Nidhi ma'am.
Thank you so much, Dr. Rajkumar. It was a detailed review of literature. So just to summarize, this was a 73 years old male who presented to our department with rapidly progressive Parkinsonism, and it was diagnosed with autoimmune encephalitis, which was seronegative because there was no detectable autoantibodies. And finally, patient improved after giving the IV steroids. So why we chose this patient for today's CCR presentation was that Parkinsonism is an infrequent presentation in the patients with autoimmune encephalitis. And it is present in around 1 to 3% of the patients. And secondly, rapidly progressive Parkinsonism, it has a huge list of causes, starting from infectious causes, inflammatory causes, malignancies, metabolic reasons, toxin exposures, the neurodegenerative dementias, the psychiatric issues, vascular causes, and autoimmune encephalitis. And autoimmune encephalitis being a rare entity, it is either overlooked or underdiagnosed, thereby leading to the delay in diagnosis and management of these patients. But it is important to make a timely diagnosis so that we can start the appropriate management. Otherwise, it has a tendency to aggravate and has an impact on the morbidity or the mortality of the patient. Secondly, our patient was a case of seronegative autoimmune encephalitis because there were no detectable autoantibodies. Thus, it highlights the importance of imaging in making a diagnosis of patient of seronegative autoimmune encephalitis. Thus, it critically highlights the importance of which the imaging can play an important role in the overall diagnostic process. So we, the clinicians, we should have a high index of suspicion of the autoimmune encephalitis in the patients who present with rapidly progressive Parkinsonism, cognitive impairment, or altered mental status, so that we can do a prompt recognition and then manage the patients with appropriate treatment like the steroids or IVIG or plasmapheresis. So that the overall outcome of the patient improves and it reduces the morbidity and the mortality of these patients. So in the end, I would like to thank the Department of Neurology, Radiology, and the Nuclear Medicine to help us in making the appropriate diagnosis